So I'm Professor Anna Whitaker. I'm the Principal Investigator of a Chief Scientist Office for Scotland funded study about keeping active physically and socially during COVID. And I'll be joined by Dr. Simone Tomaz, who is the postdoctoral research fellow on that project. And we also worked with our Sparkle team, which is Stirling Physical Activity Research Knowledge and Learning Exchange, which is our physical activity research group at the University of Stirling. So what you can see here is a clip of some of the initial findings from this study. We have got other articles under submission, and this talk will just give a little bit of feedback in terms of what we found in our project, what we did, what it means. So we did have a very long, convoluted title, so had to shorten that down to keep active physically and socially. And our aim with this project was really to look at older adults, so people aged 60 plus, and find out what they were doing in terms of physical activity and social activity, how this had changed from before social distancing was brought in and all the associated government regulations, and the impact that this had on things like social connectedness, loneliness, and health and well-being. Right at the start of this project, it was really important that we did some PPI, or patient participant involvement, or patient public involvement, as it's sometimes called, in planning how our research would work. So because of COVID, this was planned to be an online survey for the most part, but we wanted to trial that out on a few relevant stakeholders before putting it out and starting to collect our data. So initially with the Sparkle team, we brainstormed what type of measures would be appropriate to address our aims of looking at physical activity and social activity. We then put this together into a pilot survey. So this was using standardized psychometrically valid questionnaires, using ones that were appropriate for older age groups where possible, and shorter versions where possible, to minimize participant burden. We then tried this out with our PPI group in terms of getting them to say how long it took them to complete, were there any parts that didn't make sense, were there any really off-putting parts that would make them stop taking part in the survey, and just generally give us feedback. And we used that to rationalise the overall survey, and we launched that, I'm guessing that was, it was 2020, so we launched that in May 2020. So we were mainly looking at older adults, as I've said, people aged 60 plus, but we were also interested in other potentially vulnerable groups. So people with learning difficulties, people who might be shielding because of a health condition, or living with someone who is shielding, or people who might be carers. So a subsample of our study were actually under the age of 60, and we are currently looking at the impact of COVID on their social and physical activity as a separate manuscript. We used Facebook to recruit, so we were very pleased that we got over 1,400 people actually completing the survey, and we also did a telephone version if people really couldn't get online. What you can see on the right is a list of the questionnaires that the survey mainly consisted of. So the IPAC is an international physical activity questionnaire. We used a shorter version of it. The UCLA 6 is a measure of loneliness. It's a 6-item one. The EQ5D is a measure of health-related quality of life and also gives a health rating. The BPSSS is a social support scale. It's a brief perceived social support scale. So how much support do people feel that they're getting from those around them? And then we wanted to know, how had these things quantitatively changed since social distancing began? So for each of the items in these, we then said, you know, are you doing less the same or more vigorous physical activity? Are you feeling less the same or more lonely? And then we had open-ended questions for qualitative analysis, because we thought this was important to actually see, well, what were people doing to keep physically active and socially active, and pick up some of the positive messages as well as the negative messages, hopefully that way, because the positive messages could then be used to promote improving health and well-being in others if they adopted similar strategies. This slide just gives you an idea of who took part in our study. So you can see, as with a lot of online surveys, the majority of the participants were female. It was a heavily white British sample being based in Scotland. Most people were married, And you can see the proportion of those who are aged over 60, and amongst that 84%, 69% of those individuals were actually aged at the younger end of old age, which is between 60 and 69. But we did have people going right up into the 90s. About half the sample had a health condition or more than one health condition, and this is what you'd expect in this age group. And we had a nice diversity in terms of urban or rural or semi-rural places where people were living. And as you can see from the little education graph, as is common with a lot of surveys, our sample were at the more educated end, with the majority having at least an undergraduate degree. 12% of the sample also were carers, so we're able to ask a bit about that, and particularly in the younger age group. So what were these people doing? Well, when you look at this little graphic on the left and see that 5 people was the average number of people that folk had in their social network, and they saw them on average 5 days a week, that doesn't sound too bad. It sounds like moderate social activity. It's perhaps less positive when you look at that social activity spread across the 5 days of the week that they saw people actually only added up to just under 7 hours. When we asked people how this had changed because of COVID-19 restrictions, you can see highlighted the majority felt that their social network size, it was a bit smaller than the network size they used to have access to. They felt that they weren't seeing people as frequently. And when we asked about social contact, this could include online social contact. It didn't need to be face-to-face because obviously that wasn't possible for lots of people. People felt generally that they had less social contact time. But interestingly, most folk thought that the quality of the social support they received was about the same as prior to COVID. We've got quite a lot of the sample feeling more lonely, although some reported this being the same. And we've got most people reporting their health as being around about the same. On the other hand, to physical activity, something we're often interested in, which is sort of determined separately, is how much sitting down people do, because people can be very physically active, but still spend a lot of time sitting down, whereas others can spend a lot of time seated and not do any compensatory physical activity either. And in this sample, we found that people were actually sitting on average nearly 6 hours a day, and a lot of that was due to screen time, whether that was watching TV or their social contact had to now be on screen, or their physical activity was now on screen, or partly through their work. This was quite high, and then you can see in the table, not unexpectedly, screen time and sitting time increased for the majority of our sample. Now at this point, I'll hand back to Simone and she can talk you through some results.
Great. Thanks, Anna. So as you can tell on this graph, we found that physical activity in the sample was relatively high. And perhaps this is not surprising. As Anna mentioned earlier, education level was high, but also deprivation levels among our sample was quite low, and not quite evenly distributed across all levels of deprivation. We also found, as Anna mentioned earlier, that a lot of the participants were at the lower end of the older age spectrum. So we would expect that in a typical sample that this would be a little bit a slightly more active sample. One of the big things that we found was that walking was a massive contributor to physical activity. So in accordance with the UK physical activity guidelines, we found that about 3/4 were meeting the guidelines. Time spent being physically active per week was 10.5 hours, which is really high. Also not particularly difficult to find in a self-reported questionnaire because there is some social desirability bias as well. And of this, about half was walking. However, another important consideration, and I mentioned this earlier, is that strength training is really important, and engagement in strength training for this particular sample was very low at about 13%. And next slide, please. What we did find is that some people did use the social distancing or lockdown rules as an opportunity to be more active, and this was, as expected, particularly through walking. 26% of the sample had reported walking more, and one of the examples given was a participant, a 68-year-old female, who said that they hadn't used public transport since lockdown. They've just chosen to walk everywhere, and they intend to continue to do so. Approximately 40% of the sample reported walking less, but also mentioned that they were doing other physical activities. So one of the participants, a 72-year-old male, had said they were doing more gardening, but less walking. And many of us might remember that summer of 2020 was actually really good to us in Scotland. And then 34% of the sample reported walking around the same amount. And one of the anecdotes from this was a 62-year-old female that said that they were just trying to keep their walking up. They used to walk in a group, but now they are doing it otherwise, although they did certainly miss that social component of their physical activity. I'll just explain how to read these graphs. So all of these graphs represent the relationships between the variables while keeping all other important covariates constant. So to give you an idea of some of those, we looked at age, we looked at gender, rurality, deprivation, well-being, social time, screen time, and physical activity. On these graphs, the dashed red line represents the reference point, when all factors are kept at their mean level. And so the graph represents a deviation from the average. The gray shaded area represents credibility bands. So the greater the gray area, the greater the uncertainty. And you can see in the first graph on the left that there was quite a lot of uncertainty as the social network size increased. If you look on the x-axis, you'll see a rug, and this indicates the number of responses received. So again, if you have a look on the left-hand side, we had a lot of people responding that their social network size was between 0 and 12 people. But then as that got higher, we had some people who were saying that their social network size was closer to 100 people. So based on this explanation, we can see that a smaller social network, roughly up to 20 people, was related to higher loneliness, as we would expect. We also found an increase in social support, or perceived social support, was related to a decrease in loneliness. And again, this is something that we would expect. And lastly, on the right, we can also see that health rating and loneliness decreased with an increase in self-rated health. Next slide, please, Anna. Further to that, what we could also see was that walking was related to better well-being. However, we only saw that relationship up to about 300 minutes of walking per week, where certainty decreases. So too few people were able to report that for us to make inference on that. And on the screen, on the graph on the right, we can see for screen time, there is less certainty beyond values of 5 hours per day, but the negative association does persist, which shows that more screen time is equal to poorer well-being. Next slide, please, Anna. This graph shows the relationship between the categorical variables. So I'd listed some of those earlier. And based on this graph, we can see that females tended to have worse well-being and higher loneliness than males. We also find that higher PA, or physical activity levels, were related to better well-being, and this is certainly one of the positive outcomes that we found from the study. And lastly, those with less than ideal sleep, and this is using the National Sleep Foundation guidelines, had worse well-being, which is something we would also expect as well. Next slide, please, Anna. So what does this all mean? The first point that we wanted to highlight was addressing loneliness and social support is particularly valuable for well-being in older adults. We also found that physical activity may be an important recovery strategy for well-being in older adults, as well as other vulnerable groups, although that's not yet written up. We found that walking can be a socially distanced yet sociable physical activity to maintain well-being, and in that way, walking kind of kills two birds with one stone. And strength training for healthy aging absolutely needs to be emphasized. We didn't do too many stats digging into this, but the fact that the report of it was so low certainly means that it needs attention. Lastly, what we also found is that digital technology helped some older people maintain their physical activity, and most older people to maintain their social activity. And so as much as digital technology use has increased, it's certainly not the be-all and end-all, and there's definitely still a lot of room for people to have face-to-face interaction when it comes to physical activity and social activity. And exciting news in addition to this is that we're actually busy with a follow-up study for some of these participants. We had started that towards the end of last year, and we're really looking forward to unpacking some of the results in approximately 380 participants that we were able to follow up. Thanks.
here's who we are, and thank you for listening